pressure on me on the back end. Okay. All right. We call the Committee of the Whole to order. Can we get a roll call?
Mr. Young?
Here.
Mr. Furman? Ms. Nittany Dyer? Here. Mr. Cowan? Mr. Torres? Dr. Hahn? Ms. Newman? Ms. Root? Ms. May? Here. Ms. Woodruff? Here. Foreman for financial.
All right. Thank you. Our first public comment. Any from in the room or any from, we have one in the room. Nobody online. Okay.
Evening.
Good evening.
Or not so good. Fred Cummins, President Alliance for Mentally Ill Oakland County. You may recall me bringing your attention to this book by Dr. Thomas Insel, former director of the Institute of Mental Health, National Institute of Mental Health. And I handed out this sheet that has some quotes from this book by Dr. Insel. Part of the theme of his book is focus on treatment that goes beyond crisis and beyond medications. He gives a somewhat different example of children who have a severe cancer, early age cancer. And a couple of decades ago, 90% of the children died. Now, 90% live. There aren't any new medications. What's changed is the treatment regimen, which goes beyond the acute care, tries to get them early, and goes beyond the acute care to try to go through a series of treatments that change the illness and the condition over months and years, possibly. And I think it's important to realize that the same kind of phenomenon can occur with people with mental illness, because their illness changes and their needs change. But for the most part, our care doesn't. We take care of the crisis, and we figure we got them on meds, so that's it. So we need to pay attention to that. The particular thing I quoted here has to do with CCBHC, which is Certified Community Behavioral Health Care Center, which is a fairly new state international program that you may have heard of. There's a lot of talking about this, and I think that will be a move to spread it across the state in terms of CMH services. Right now, we've got some direct care provider like CNS performing as CCBHCs. That's really not the right answer, because fundamentally they're driven by profit, which means they're going to cherry pick the people that they actually serve, and the rest is your problem. So this is not a program to say we're going to find a way of finding somebody else to be responsible. It's a program that says that we're responsible, and we're trying to assure that we are capable of giving them services, and they need to start early, and they need to continue beyond crisis and into care beyond that. And we've got the clubhouses are kind of an example of a follow-on form of support. They're very important, but they're not taken seriously. And I suspect right now they're underfunded, and we're on the track, maybe on the path of getting rid of them, because they aren't fully appreciated, but they're very important. But that's kind of the other end of the spectrum. So draw your attention to this, because he's talking about what CCBHSEs are supposed to be, which is, I'm not sure it's the way it's being done. It's being done is, now we can send these people to somebody else, and they're not our problem anymore. Well, this says, they're always your problem. If you happen to be able to tap into something else, that's fine, that's good. But they're always your problem, so just want to clear that up.
All right, thank you for bringing that to our attention. Okay, item 1C, I need approval for the agenda. Can I get a motion?
Moved. Support.
Motion and support. We can just do a voice vote, right? All in favor by aye? Aye.
Aye.
Any opposed? Motion carries. Okay, item 2, Finance Committee. Financial review is our first item. Anya, I think you're, I see the slide, and you're online.
Yep, can you hear me okay?
Hear you clearly, thank you.
Okay, bear with me 1 second, I'm just adjusting my hair. One second. Sheila, right now, all I can. Let me hop out a second and make sure that it's not, that all I can see is picture right now. Oh, wait. So I have the room, I don't have the slides right now. Oh, there you go, now I do. Okay, so you're looking at, okay. This is January financials. You're looking at right now the October, January. So relatively flat. We were flattened out over the last several months. There's not a significant increase that we've seen over the last several years. And we should expect that through the leader of the public health emergency. Next slide. Okay, what you're looking at here, you said you're not hearing me well. Is that true?
You're cutting in and out a lot.
Is that any better?
Yes.
Okay. All right. So what you're looking at now is the assets from September compared to now. So you can see our assets are up a couple of $1 million. Receivables are down as we make payments out on anything that was accrued for prior fiscal year. Other assets are roughly flat, and then capital assets continue to go down with depreciation. So this is liabilities. So this is liabilities compared to the end of last fiscal year to now. So you can see liabilities are down by about $5 million. Due to state is roughly flat. Employee payables is flat. And then long-term debt, again, continues to go down with payments that are made. So net position is comparing September 30th to now. So you can see our net position, our total assets are slightly down. Our total liabilities are slightly down, but our net position is slightly up compared to that point to the end of the fiscal year. Revenue, now this one compares last year at this time to this fiscal year. So you can see revenue is up pretty significantly, and that's primarily related to the CCBHC. General fund is exactly the same as it was last year. same as county. And then all other includes some other things like grants and other revenue streams that aren't otherwise captured in the prior ones. Expenses, so you can see administration is up a bit from last fiscal year. Provider network is up about $30 million, but that's primarily related to the CCBHC and then the additional funds we've pushed out with the direct care wage increases. Grants are up a bit, and then all other is up just slightly. So total revenue is up to 149 million. This year over last. Total expenses are up about the same, and then net income is up by about 2.5 million. These are the top 15 providers in order of the amount paid for the month. Definitions, and then I can take any questions.
So Anya, are you still reflecting Easter seals and Mork separately?
Yes, we still have them under two separate contracts.
Okay.
So they are still separately.
Okay, and then you might have said this in the beginning when you were cutting in and out, but at our last finance committee, you had mentioned you were essentially, monitoring given the potential of changes with Medicaid. What are your concerns, if any, right now?
So we're in the process now of reviewing our revenue trending for the fiscal year down to the rate cell level. So my hope is to be able to bring you an amendment next month that will include some updated projections and then updated demonstration about how CCBHC impacts our financial statements. So what I'm looking at right now is it's roughly flat from where we started, which you can see in the eligibility trend. But the reason I want to do it down to the rate cell level is because that will be very, very important as we go forward in the public health emergency ends to really watch by population and by group the change in eligibility. So right now we're going to update what we've got and then keep a much closer eye on it going forward, just because it will start to change with the end of the public health emergency.
Okay, thank you.
Yep.
Any questions from committee members? No questions. Good report.
Thank you.
We're on policy.
Moving on to policy, Frances Carley and Christine Burke.
Good afternoon. I'm Frances Carley, Deputy Director of Strategic Initiatives, and I'm joined here by Suzanne Weiner, Director of Communications and Community Outreach, and we're excited for the opportunity to present the Needs Assessment Survey to the Committee of the Whole today. I'm not sure that this is the correct slide. Oh. Oh, okay. Yeah, the landing page is where I was starting. Okay, so through the annual survey, OCHN will gather information from persons served and their families, community stakeholders, providers, and also, of course, OCHN's board members to determine the organization's priorities for the upcoming fiscal year 2024. This feedback will provide the foundation for OCHN's annual plan and will help determine the activities and the objectives that OCHN should focus on in this upcoming year. So to start, we have a few key updates to the survey design in 2023 in order to keep expanding on our successful response rate last year. First, we made a priority to make the survey more equitable, and this means offering both a shorter and longer version of the survey for people receiving services so they could choose which one they preferred. We also removed some of the questions that seemed redundant and extended the survey unnecessarily. And we included a question to broadly assess some factors that could possibly impact social determinants of health and quality of life. Second, we included questions about crisis services and people's experiences when requesting care in order to gain a more clear picture from the perspective of people served, families, friends, law enforcement, and also other service providers. And then third, we included some additional questions for the direct support professionals to better understand their experiences and to help address workforce issues that are impacting the state more broadly. So then in terms of collecting input on the content of the survey itself this year, we started in early February. OCHN's Chief of Staff, Christine Burke, and I presented the initial draft design to the Board of Directors during a study session. So there we discussed the questions, timeline, content, and other items about the survey. And then since that time, we went out, received input on the design from people served through some of the work groups. That included Citizens Advisory Council, the Recipient Rights Advisory Council, and the Strategic Planning Committee. Of course, we also incorporated changes that were suggested by the board and OCHN staff more broadly. Then the timeline that we're looking at for the needs assessment and the annual plan itself, we have several major milestones planned out for the next coming months, and this process started in January, will go through early fall. And again, the needs assessment is really the first step in this annual planning process. So it's the foundation, it's really the building block for the feedback, the findings that will help set the priorities for the annual plan in fiscal year 24. After completing the needs assessment, which will be open until the end of April, we will present the findings to the board in May and with a final report, and then we'll launch the annual planning process internally and bring those milestones, those steps to the board as we go. So the survey process will include some in-person visits, drop-in centers, and other opportunities to get feedback from people that we serve directly. And I'll pass it off to Suzanne to discuss those steps next.
Hi, everyone. Thanks, Frances. As she mentioned, I'm Suzanne Weiner, Director of Communications and Community Outreach. Just want to talk a little bit about our communication plan to get the needs assessment out to the community and the people that we serve. As you can see on the slide here, we have a very comprehensive distribution plan electronically. We'll tap into our partner, Oakland County Health Division, to utilize their electronic listserv, which is approximately 100,000 individuals or more. Every year we ask them to submit that or send that assessment out to their listserv and get quite a bit of feedback from that listserv. We also will continue, as we continue to host virtual media events or trainings, we'll continue to insert the link to the needs assessment in the chat to ensure individuals have access to the needs assessment online. And then we'll distribute it ourselves using our constant contact system. We'll be doing that biweekly in both March and April. Once it's approved from the board in March, we'll start right away. We'll hit the ground running in March and start pushing it out to our listserv, which is approximately 10,000 individuals. And those include our faith-based community, we have our hospital and community partner contacts, we have a lot of individuals that we serve and our allies, as well as our officials, county officials, local and county officials, and our network staff, as well as our school partners. As Francis mentioned, we are going to be doing some in-person presentations where we will bring hard copies of the needs assessment to those in-person presentations. We're going to be at our work groups for person served, so think of CAC, BEST work group, RRAC, strategic planning work group, and the like. So we'll be at those work groups between Francis, myself, and Christine Burke. Will be going and meeting with those groups and talking about the needs assessment and encouraging them to complete the needs assessment, both either electronically, if that works for them. We'll also have hard copies with us so that they can complete them right then and there. As Francis mentioned, we have already got I believe most of the clubhouse and drop-in centers booked between the end of March and throughout April, where we're going out and presenting the needs assessment and encouraging individuals to complete the needs assessment right then and there. Again, we'll be bringing hard copies with us, or we'll also encourage them to use the electronic version of the needs assessment. Next slide. Just another kind of overview of how we'll be pushing it out, both media and hard copy as mentioned. We'll be posting weekly on our social media site with the link to the needs assessment so that individuals can be aware of the needs assessment, and we can continue to promote it through our social media platforms, which include Facebook, Instagram, Twitter, and I'm missing one, LinkedIn. So we'll make sure that we put that out there on all those social media channels, as well as we'll be putting a press release out to our local media to let them know that the needs assessment is available and direct people to our website to fill out the needs assessment. As far as hard copy, we do make sure that we get hard copy out into the community. We typically do quarterly or periodic mailings to our service sites, and we're gearing up for a big one coming up at this month, end of this month. We'll be putting that out to our 300 service sites. We'll be including a hard copy of the needs assessment for individuals served, as well as the direct support professionals, and include a prepaid return envelope to ensure that they return those materials back to us. We also provide extra copies for our court providers so that they can include those in their lobbies, and they can help to encourage individuals to fill out the needs assessment. Obviously, we'll distribute it to you as well to ensure that we get board participation, and we'll post it on Boardable and continue to collect feedback from you via Boardable. I think that's all I have. So do you have any questions for either of us?
Any questions? Dr. Hans.
Yeah, thank you for this presentation. Thank you. I think we are getting to the starting line with the way it should be done. I just want a little bit of clarification as to the number 100,000 is from the county health department's database.
Yeah, they have a Gov delivery system that they continue to get subscribers, and
Okay.
it's from a number of different areas that
Okay.
people subscribe, and we tap into. They're a great partner of ours, so we ask them to distribute it via their listserv.
And the number 10,000, is that the people that we serve, or?
The
What
10,000 contacts are in our Constant. We have a system that we use. It's called Constant Contact, and we have about 10,000 subscribers to our listserv as well,
Okay.
which includes as in faith-based, schools, local officials. So it's a number of different contacts from different categories and different sectors.
So what percentage of the people that we serve receive this survey?
As far as a percent, we have a number of individuals that we serve and their families that are part of that listserv. As far as I don't have an exact percentage of the number, but we do have quite a few that are either one of the listservs, one of the sectors that are part of our listserv, as well as there are individuals that are served on our work groups, and they are all included on that listserv as well.
Yes, but I think it would be important to get the feedback from as many of the people that we serve, because that's what we are here for. And I don't know if they will need support with that, but that's down the road, just to find out how effective we can be, at least reaching out to each of the people that we serve. Thank you.
I absolutely agree. It's important to get to the people who serve. That's why we want to go to the work groups and go to the clubhouses and the drop-in centers to try to work directly with the people and help them to complete the survey if they have any concerns or
Yes,
issues with completing
and
it.
I understand that not everyone is reachable also, so thank you.
Thanks.
Are there any other questions? I just have one question. What was the total number of respondents last year?
It was about 900.
Okay. And that was an
Um,
increase over the previous year, correct?
Yes.
Okay. Thank you. Thank you very much for your presentation. Next, we will have Adam Hamilton and Angela McGee. Welcome.
All right, thank you. Good evening. Thanks for having us tonight. We're going to talk to you a little bit about our CIRC committee. I'm Adam Hamilton. I'm the clinical director here, and this is Angel McGee. She is a quality analyst on our quality management team. All right. So just to get us started, I want to get everybody oriented to a few different definitions. You'll hear some of these things come up. We'll go into more detail about what they are as we get into the presentation. So when you hear incident report or incident, generally what we're referring to is anything that would adversely impact normal service delivery or the normal course of activities in a setting such as a group home or a program where people are attending. Incidents could include someone getting hurt, someone getting sick, suspected abuse, a medication error, the passing of somebody receiving services. OCHN receives incident reports every day. They're processed, they're coded on an ongoing basis. And when an incident report is coded, it's determined if it's a risk event or a critical incident. The CIRC reviews all of the critical incidents. Some of those need to be reported to the state immediately, so we have a process for that as well. A sentinel event is really what the CIRC is here to do, is to determine if incidents that are deemed critical incidents also rise to the level of being sentinel events. So all critical incidents are reviewed by the CIRC to determine if they meet that definition of a sentinel event. Just for example, a couple of examples of like a risk event would be 2 or more unscheduled admissions to a hospital for medical treatment within a 12-month period. So when those types of events come to our attention, those are something that Angel's team also looks at, and those can be brought to the CIRC or brought to the attention of the clinical team as well. So lots of eyes on, lots of involvement in looking at these different types of things. Root cause analysis is the process that we engage in with our core providers to respond to an event when we determine it to be sentinel. So we'll talk a little bit more about what that looks like when we go further into the presentation. You can advance to the next slide, please. So this is the CIRC committee here. These are the staff at OCHN who make up the CIRC committee. It's staff from the clinical practice team and the substance use disorder provider network team. Angel and other members of the quality team will attend. Our director of rights and advocacy, Vicki Suter, attends. Our chief medical officer, Dr. Pozios, attends. And our chief clinical officer, Kim Flowers, will attend as well. Recently, this year, we've had some changes to process, and we're actually involving our nurse case managers as well, too. So I'll talk a little bit more about how the process changed to include them. Go ahead and advance to the next slide. The committee meets weekly. So throughout the week, preparing for the meeting, one of the things that happens is that the clinical analysts, working with the nurse case managers and other staff as needed, are reviewing critical incidents to prepare to bring them to the CIRC to discuss them further, where the CIRC will review them as well. Again, that's where that CIRC meeting is where all those critical incidents are looked at, and we can make a determination about what response is appropriate. We request RCAs through the CERC process, and then on a monthly basis, when the root cause analysis or the RCA, excuse me, is completed, the CERC reviews those as well to see if we are going to accept that response from the provider, or if we feel like they need to do some additional steps to address, whatever issue was found through the committee review. This slide just gives you a little bit of an overview of the volume of incident reports that are reviewed. So I think what we see generally is, fairly stable trend line with 2019 kind of as an outlier. I don't have a good explanation for why that is an outlier. Some things going on that year could potentially be an issue with data or duplicates in the data. It was around that time we also started directly contracting for residential services as well. We had vocational services under our direct purview as well, instead of delegating those things out. So we were doing some training on incident reporting and trying to encourage, providers to do best practices around that. When we got into 2020, of course, that was the first year of the pandemic. So a lot of activities that were typical, where people would go out into the community, they would go to programs, those things were not happening as much. And I don't think we've seen a full return to that level of activity. Those types of activities can generate some reports because you've got people moving about the community, participating in activities. So I suspect we see a little bit of a downturn in 2021 related to that. It's just people not getting out because of the pandemic for safety reasons, and therefore, maybe less falls, less things like that would generate some incident reports. The next slide just breaks this data down further in by code and by quarter, so you can kind of see each type of immediately reportable event. And what we see here is there was 18 total in fiscal year 22. In the prior fiscal year, I believe there was 12. So that marks a bit of an uptick. I think one of the things that explains the variance, we had one service site that generated 5 of these because all the individuals at that service site needed to be relocated temporarily due to some criminal activity in the neighborhood. So that explains 5 of the 18. That's an appropriate reporting of those events, but it does kind of contribute to a trend up in the total number there. Beyond that, there's not any major departure from the previous fiscal year in terms of the number per code. This breaks it down on an average per month. So we have 1.5 per month in fiscal year 22. That's immediately reportable events. Again, immediately reportable events are things that we have to report to the state when they occur. So we take those very seriously. These are also reviewed by the CERC. Oftentimes we kind of drop what we're doing to review these and make sure we can get a sense of what's going on right away in case a more timely response is indicated. Okay. And I'm going to hand it over to Angel. She's going to talk a little bit about risk events.
Good afternoon. So this slide just shows the categories of risk events that were reported by code for the entire OCHN network. For both fiscal year 21 and 22, there were 180 risk events reported. Let's see. So M41, which is 2 or more hospitalizations due to illness or medical condition, was the highest reported risk event throughout the network for fiscal year 22 at 53%. And that was followed by M36, which is emergency medical treatment due to injury from self-injurious behavior, and that was reported at 33%. Next slide, please. This table just shows the total number of each type of risk event that was reported by quarter in fiscal year 22. Fiscal year 21 and 22's totals were the same, 180. There wasn't much variation in the type of risk event reported. M37, which is hospitalization due to injury from self-injurious behavior, did decrease by 7. And V21, harm to others, resulting in emergency medical treatment increased by 5. Next slide, please. This slide just shows the per month average of different types of risk events as they were reported in fiscal year 22, and they are ranked by how frequently they occur. So as I stated earlier, M41 was the highest reported risk event. There are about seven each month, and that's followed by M36, and there are about 5 each month. Next slide. Okay, so this just shows the number of risk events reported by population. I'll start off with adults with MI, mental illness. The MI population accounts for about 30% of the risk events reported in fiscal year 22. So for the MI population, M36 was the highest reported at 57%, and again, that's emergency medical treatment due to injury from self-injurious behavior. And then M41, which is 2 or more hospitalizations due to illness or medical condition, was the second most reported. Next slide, please. This shows a breakdown of risk events by quarter, and this is for the SED population. As you guys can see, the number of risk events is at an all-time low right now. The SED population accounts for about 18% of the risk events reported for fiscal year 22. 53% of these risk events were M36, which is emergency medical treatment due to injury from self-injurious behavior, and then 31% was V17, which is the arrested recipient. Next slide, please. And lastly, I'll show the breakdown of risk events for the IDD population, which accounts for about 44% of the risk events reported. 81% of the risk events were M41, which is 2 or more hospitalizations due to illness or medical condition. That was followed by M36, which is emergency medical treatment due to injury from self-injurious behavior, and that was 12%. This pie chart shows the categories of critical incidents reported by code for the entire OCHN network. For fiscal year 22, there were 703 critical incidents reported. Oh, I'm sorry, go back, please. Okay, so pretty much I just want to highlight that M26, which is emergency medical treatment due to injury, was the highest reported critical incident for the network at 47%, and that was followed by deaths, which was 33%. Next slide. This slide just gives the total number of critical incidents by quarter. The IDD population had the most critical incidents. 67% of those critical incidents were M26, which is emergency medical treatment due to injury, and 25% were deaths. The MI population had 267 critical incidents, and although the IDD population had the highest number of critical incidents for the entire fiscal year, the MI population had twice as many deaths and 5 times as many arrests as the IDD population. The SED population only had 115 critical incidents. 48% of those were attributed to V17, which is the arrested recipient, and the other half was attributed to M26, which is emergency medical treatment due to injury. Next slide, please. And I'll hand it back over to Adam.
So this slide looks at the average per month by different type of critical incident. And so you can see that on an average month, we're totaling approximately 60 critical incidents. And advance to the next slide. This just looks at a trend across several quarters by population. This is individuals with intellectual developmental disabilities. You can see it's fairly stable over the past 2 to 3 years, and no major swings upward or downward in fiscal year 22. Next slide, please. This is children with serious emotional disturbance. Again, some peaks and valleys, but not wild swings, fairly stable from quarter to quarter, nothing, no particular outliers in fiscal year 22. And critical incidents for adults with mental illness. down toward the end of fiscal year 22, but within kind of the normal range that we would see in years prior. So no major outliers again. So this slide starts to look at, of all those critical incidents that were reviewed by our CERC, so 703 total, 12 were deemed to meet the definition of a sentinel event by the CERC. And this breaks it down by type of critical incident that met the definition of sentinel event. Compared to prior years, 12 is, kind of in the typical range. It was 10 in fiscal year 21, 12 in fiscal year 20. So fairly consistent, right about that, right around that amount. Some common reasons that we, as the CERC, deemed an event sentinel, it could be related to concerns about coordination of care. That could be coordination of care within the agency. A case manager not coordinating with a prescriber, for example, would be something that created concern for us. Could be coordination of care with the medical providers if somebody had an adverse incident related to their physical health. Perhaps not referring a person to the clinical pathway for suicide care would be a concern that would lead to an event being deemed sentinel. So if you were to compare by category to fiscal year 21, there is not major variance from type of sentinel event. So in fiscal year 21, there was 4 non-suicide deaths that were deemed sentinel, 1 investigated death that was deemed sentinel, 3 suicides, 1 arrest, and 1 for emergency medical treatment that were deemed sentinel. So fairly consistent. Go to the next slide. When the CERC deems an event as sentinel, when the CERC concludes that the critical incident meets the definition for a sentinel event, we embark on what's called a root cause analysis. And this is a process where we work with the provider, we ask them, the CERC, members of the CERC develop some questions to ask the provider to help them begin to investigate what was really at the core of the problem or what was going on in the situation that resulted in the adverse event. The goal is to help identify causal factors. We want providers to identify things that they think might have contributed to the outcome, and in identifying those causal factors, we'll ask them to address them through the root cause analysis, where they'll also develop an action plan. And the action plan needs to also have a measure of effectiveness to it, so that they can see when they do the interventions in the action plan that it's actually having the intended impact. The goal of this is to really, again, help to identify the core issues that led to the adverse event. It's not supposed to be a process of shaming or being critical or anything like that. We do try to be collaborative. We try to offer support or insight where we can. Again, with the goal of really working to determine what's at the root of the problem, so that it can be corrected and prevent similar events from occurring in the future. Go ahead and advance. Okay. So part of the work of the CERC, or the bulk of the work of the CERC, again, is reviewing those critical incidents. We also do things such as look at trends. Angel or other members of her team will come and they will present on the risk events. One of the things that we do on a regular basis is try to look at trends in the data so that we can identify other opportunities to make systemic improvement. In fiscal year 22, one of the things we worked on was actually reducing the amount of time between when we learn of an event and when we actually make a determination about when it's sentinel. This is a PIHP contract requirement that we have. It's a tricky one to meet because they give us a very small window. It's actually 3 days from the time of the event unfortunately, in some situations, we don't learn of an event within that 3-day window, so that makes it very challenging to hit kind of the 100% goal that we have. Although this year, one of the things I mentioned earlier was we've started to involve our nurse case managers in this process as well. And what they can do is work with us outside of the actual committee meeting to make a determination in situations where there's been a death of an individual or there's a medical situation, and we need a medical person to review that. And actually getting them involved has helped us really reduce. We've improved by 20%. We think we were around 53% we were reviewing within 3 days, and now it's up to 73%. So we've done much better now that we have the nurses involved. Sometimes we notice some concerns. It'll be variation from one provider to the next, and even though they may be of similar size, serving similar number of people, we maybe suspect like some underreporting is going on. That might prompt us to reach out to that provider, offer training or technical assistance. Maybe they have new staff or something like that, and make sure that they are reporting timely, reporting each. So, sometimes people have a misunderstanding of a policy or something like that, and they might not be reporting when they need to. And sometimes what we've learned is actually there are providers who are reporting a lot, and maybe in situations where we wouldn't intuitively think they need to, but we encourage them to do that anyway. It's better to simply submit the incident report, let us make determination about how to code it and what's appropriate. So, that looking at data like that prompts us to take a closer look at just patterns of reporting. I mentioned concerns regarding coordination of care. We can identify trends around whether or not our policies or protocols are being followed. The one I think I mentioned before was not referring people to the clinical pathway for suicide care. So when we notice those kinds of things, it gives us opportunity to intervene. Sometimes we find that we need to actually update or improve practice guidelines or protocols. Sometimes we find out that we can bring it to the attention of a provider. They can do more training of their staff, those kinds of things. Go ahead and advance to the next slide. So the impact that this has on individuals receiving services is that it really helps us connect with the providers and help them identify ways that they can improve services so that adverse events are prevented through proactive means. That's fundamentally the ultimate goal. When we make changes to protocol, when we make changes to practice, what we do is we improve things to prevent these types of events from happening. Sometimes we identify, this says, gaps in services, areas where maybe we don't have a protocol, maybe we haven't promulgated practice guidelines that we feel outline best practice, or there's a gap in an existing protocol, or a program that would be advantageous to bring to the system. So we can identify those things through the CERC process as well. And of course, we get a lot of meaningful feedback through the completion of the root cause analyses to the RCAs. We learn from providers what they're doing to improve things. We learn from providers through that process where they feel they might be struggling too. This is, the ultimate impact is that this is really part of a process of continuous quality improvement. These are the relevant policies and procedures that we have. This is what we follow. All of these things do, as you may recall from last month when Marquita presented on the QAPIP and I assisted her with part of it, these feed right into our annual QAPIP process, and we report up to the department on those things, or on the things contained in there, including all of the activities of our CERC. The financial or funding impact associated with this would be the staff time that it takes. There's a considerable number of staff on that committee. We meet once a week, so that is probably the big where the bulk of the cost is associated with this. Of course, that staff time is also felt at our provider network, where we ask them to do root cause analysis. They have their own CERC where they review things and complete those root cause analyses. Of course, the investment in time there, when it helps people receive better outcomes, that is obviously well worth the effort and the time, and serves our overall mission of providing quality services to people.
Are there any questions of Adam and Angel from the board? Dr. Hans.
Yes, thank you for this comprehensive presentation. A lot of items to cover. I have a couple of questions. If you could give examples of the relocation of service site and also the investigated death. And my other question is that you gave the raw numbers in your report. Could you give us by percentage of the different populations surveyed in your next report? You don't have to do it on this one, because when we compare with one group with the other, it's like 9 in one is too many, and as versus in a different group. So yes, thank you.
Yeah, sure. I think we can certainly do that. That report gets to be pretty heavy with numbers, so any input you have on how to make it more digestible to you is useful for us.
Yes, I'm sure that this is for reporting requirements also. You use that data, so thank you.
Yeah. So an example of when individuals would be relocated, sometimes it's because of like problems with the physical structure of like if maybe a furnace goes out or there's a roof leak or something like that, and so if individuals have to be relocated for a reason like that, the providers are obligated to report that to us, and then we have to report it up to the department. It could be power outage, for example, things like that too. Yeah. An investigated death, so it may be the case that it's not an attended death, it's not occurring in a place where there's a medical professional or something of that sort, and so there will be police involvement to investigate the cause of it. So we would certainly look at those. Actually, one of the things that I should have mentioned that inhibits the CERC from sometimes doing a timely reviews, we have to wait for a death certificate too, and that gives us a lot of information about what was going on, what happened, and so we have to request those. And in the case of an investigated death, that takes can take even longer to get that. So. Yeah.
Yes, you may.
So the relocation of service site, so it's usually for some physical reasons, like, the place of residence or location of the service site.
Yeah, that's a common reason.
Yes.
In the case, I think in the case of the 5 individuals who were relocated in this example tonight, there was some criminal activity in the neighborhood. So for the safety of those individuals, they relocated them. Yeah. So
what when there is a misfit of for example, in a with a residential provider, for example, if that's a misfit with the maybe co-residents or staff is not the appropriate, are those reported somewhere in this?
Yeah. So if someone were to move under those circumstances, I don't think that would typically be reported unless there was, there could be like behaviors that hit other codes that might get reported that are associated, like if 2 roommates have a physical altercation, perhaps, or something like that. Typically, if somebody were to go to a hospital as a result of what you describe, that might generate an incident report. It probably wouldn't be coded as a relocation of an individual, but would be coded using another code. And if somebody just moves because it's not a good fit, and that's handled through the person-centered planning process, and it's done through developing new goals and in collaboration with the family and the individual to find a new residence, that wouldn't generate probably any incident report. That's just kind of, we want people to have the choice of where they live. So, yeah.
Any other questions? Mr. Lansman.
Thank you. And Adam and Angela, thank you very much for your presentation, the effort know a lot goes into it. So this is fiscal year 2022, so that meant that it wrapped up September 30th of this last fall,
Mm-hmm.
and then was reported. Is this the report that goes out to the state by mid-December, I assume?
When we, so you approved the QAPIP last month. Some of this is contained within that. I think there is various reporting, some of these things we report on an ongoing basis. Some of these things are reported in the QAPIP, and then I don't know if you report anything in December?
No, I don't report anything in December. This data I gather is typically from reports I do on a quarterly basis, and I present to the QM team, the CERT committee, and then sometimes I'll discuss with providers as well.
Okay. And you guys mentioned that it's come up a couple of times, that there were 5 members or 5 individuals that we had to relocate. And because our service provider had to relocate them, we got dinged for was that a Sentinel event, 5 relocations. There was no way to filter that out. The state doesn't recognize things are outside of our environment.
It was an immediately reportable event. We looked at it. I don't believe it was deemed none of those were deemed Sentinel. The provider handled it appropriately, is my recollection. So I don't think we were, dinged or it wasn't. We reported it appropriately. So
I know when we have investigations, if we do it outside of 90 days, we get dinged. And sometimes that can't, because you're waiting on death certificates, that can't be helped sometimes. So
we don't control for all the variables.
Exactly.
Unfortunately, it makes it somewhat challenging. Yeah.
And the state is the state, and I get that. What was the other question? So of all these things, and I think you mentioned there were, I'll get the number wrong, 18 Sentinel events. How many of those, based on follow-up investigation, based on going through root cause analysis, Ishikawa, or flow diagram, whatever type process you use, how many did you guys figure out were preventable, that could go into some way to prevent it from happening in the future?
So I think there was 12 Sentinel events. There was 18 immediately reportable, I think.
Okay.
Yeah, I think if I'm remembering correctly. We can't know unequivocally that something was preventable. We're limited in terms of the scope of the information we have to basically what's in the medical record, what's in the incident reports. We will confer with the provider if we need to, or sometimes we will talk to the rights team here if we think that there's information that can be gleaned. We're kind of operating from the assumption, and I think we want to always do this, that if we continue to improve things, that all of these things are preventable. It's clearly going to be the case in some situations that's not true. But that is kind of the attitude or the philosophy we take into it, if you will, is that we can make the improvements to head these things off.
I get that. I recognize it. Not all deaths are preventable. Not all suicides are. I know we strive for zero suicide.
Yeah.
I know that. Yeah. But I'm thinking of it like this, that if we have a situation that comes up, we track the root cause to it. We recognize that I don't want to say throw a number, it's a 1 in a million chance that it could happen. It's not likely it's going to happen by that provider again. But the idea that if we know it's a condition that could happen, that we can, and that we know that there's this sounds cold, a workaround.
Yeah.
That we can't communicate that. Do we have a process beyond our CERT to communicate that out to the community at large, saying, we've had these happen, we've seen that there's a possibility, maybe not, but here's a way to stop it from happening in the future if this condition arises. That's all. So trying to make it preventable.
Yeah. I think in terms of Sentinel events, if something clearly was not preventable, that would probably reduce the probability that we would deem it a Sentinel event. It's already a critical incident. It's been coded as such, right? If it were not preventable, what that means to me is that there really wasn't much action the provider could have taken beyond what they did to prevent it, and we probably, in most cases, would not deem that a sentinel event. Now, what we will do, and I think that's a long preamble to say what I'm about to say, what we will do in situations where we're not compelled to deem an event a sentinel event, it doesn't seem to rise to that definition, we don't see that the provider really maybe did something or didn't do something that would have prevented it, we will still do outreach to the provider. We kind of informally call it, like, we'll do outreach and do a clinical concern. So it might result in a phone call or a conference call with the provider or sharing of information to help them kind of revisit the situation through a lens where they now have some additional information. So.
But some way to do lessons learned that can be shared with other parties too, because you're not getting into the specifics about this person because of the sensitivity of the nature of it, right?
Do we do that? I think probably through our QIC, our Quality Improvement Committee. Those discussions are happening. I think the clinical team, the team I'm on, we don't cast a wide net quite in that way. Usually, although there have been times when we will go to the clinical directors meeting and have a conversation with all of the clinical directors at the table and say, hey, we've noticed this trend, these are our thoughts about that, and that can result, again, in conversations about changing protocol, about, gaps in services, things like that.
I do have one question. When you were listing deaths on one line, suicide on one line, if my death was by suicide, am I listed in both categories?
No. So there is the deaths that are not listed on the line for suicides.
So the suicides are the ones that attempted but did not complete.
Suicides would be someone who died by suicide. Deaths would be, really, it could be anything like medical that occurred. Sometimes people, those unattended deaths can sometimes hit that investigated deaths code. Yeah.
All right. So if I die by suicide, then I'm not in the death column.
You're in the suicide.
Just the suicide.
It would be coded as a suicide. Yeah.
Gotcha. Thank you.
Sure.
Thank you very much for the presentation. Is there a motion from? Oh, I'm sorry, Dr. Hans.
Yeah, excuse me. I had a follow-up question on to Jonathan's question. I think, and I understand that you are not part of every clinical committee or team, but RCA would be very important in all categories, and I think that is something we should think about, because that is what leads us to what caused it and if it was preventable or not. And if it was not preventable, there has to be some process change to try to at least does not happen. But of course, you have to look at trends to come to that spot. The other thing maybe we will do at the end of the meeting. I have some thoughts that I wanted to share. Thank you.
Thank you. Zaleski, is there a motion to recommend approval to the full board from the policy committee?
So moved. Can you repeat who made the motion? May, and second, Dr. Hans?
Yep. Roll call, please.
All right, we have Dr. Hans? Yes. We have Ms. May?
Yes.
Ms. Woodruff?
Yes.
Motion passed.
Okay. Next on our agenda is the RRAC recommendation. Vicki Suter. Come on down.
Good evening. I'm Vicki Suter, Director of Rights and Advocacy. This evening, I have a recommendation from the Recipient Rights Advisory Committee for appointment to the RAC Committee. On our meeting on March 2nd, we did interview 2 individuals. We have 1 vacant position currently on the Recipient Rights Advisory Committee. Both candidates were deemed acceptable by the committee to be considered for recommendation. Upon voting for recommendation, the committee did determine they would like to recommend Amit Agrawal as the candidate to fill the current vacant position on the Recipient Rights Advisory Committee. Mr. Agrawal was a member of the RAC committee a few years past. He served 6 years or 2 terms. He is eligible based on our policy for one-third an additional last term. The committee was appreciative of his past experience as well. He was an excellent member of the RAC, very participant. He was a co-chair of the RAC committee during part of his 6 years. He's an individual that has a lot to offer. He is a trainer, understands the rights system, also assists us with our 30-day new hire rights training as well. We believe that his skills and talents would be quite a benefit for our Recipient Right Advisory Committee, so we are asking that the board will approve his appointment to the committee. I believe he was online with us through the phone, so if you have any questions, absolutely willing to answer those.
Yep.
Thank you.
Hi, Amit.
Yep, I'm here, Vicki.
Thank you.
Does anyone on the board have any questions? Okay.
And I don't have a question, but I do have a comment. I've worked with Amit several times in the past, and yes, I would agree that he would be an outstanding member of the RRAC again, and I would certainly advocate for his approval.
Any additional discussion? Is there a motion to recommend from the policy committee to move to the full board for approval?
So moved.
Seconded.
Can we have a roll call, please?
Ms. May? Yes. Dr. Hans? Yes. Ms. Woodruff?
Yes.
Motion carries.
Thank you.
Thank you.
Thanks.
Item 4, other business. Suzanne, events and outreach.
Hello again. Just wanted to mention some of our outreach efforts for March and a little bit for April as well. We actually do a Pontiac faith-based meeting. We meet with them every couple of weeks right now. And just recently on March the 2nd, we had Lori Gall, our access supervisor, come and speak to the group and talk about our access services. And it was very well received, and actually they had one of the Pontiac City Councilmen there, and it led to a request for her to come and speak to the Pontiac City Council. So that's a good trickle effect that we're getting the word out about us. People are learning what access is. So I was really glad for that. I wanted to share that with you. Also, I think we mentioned this last month that we're participating in the Homeless Task Force meeting. I also wanted to mention our Abilities Awareness event. Thank you so much for coming, Mr. Young. It was nice to see you there. It was a great event. We just had it last week. We had about 50 to 60 individuals present. We had probably about that in the room, but we also had probably a good 20 or so online. So it was a great event. We had, we were able to invite our micro enterprise back. We had a few micro enterprise in the room. So the micro enterprise are individuals who have businesses of their own, and they sell the items that they make. And I think that many of them, it was very successful. But we also were able to honor our abilities champions from both Easter Seals MORC and CLS, and you're going to get an opportunity to meet those individuals next week at the board meeting. They'll be part of our Stories That Inspire Hope next week as well. And then we had an excellent speaker who talked about the opportunities for abilities, I want to say, instead of disabilities, the abilities, opportunities that our available in our community. Talked about, this is Disabilities Network. Carrie from Disabilities Network was here to speak, and she talked highly also about the activities and resources that are available through the Parks and Recreation. So this was a great opportunity for people to learn ways that they can continue to engage in the community and be part of the community. So we're going to continue to bring Carrie back, and we're also going to incorporate the Parks and Rec activities as well so that you can learn more about those opportunities that are available for people that we serve and beyond. Also wanted to mention the next day, we were really busy last week. We had a lot of events. The next day, the American, Dr. Pozios put a really great program together with the assistance of Colleen, his assistant, and communications team tried to help a little bit as well as training. But the American Psychiatric Association Foundation asked to come and speak to our school personnel, and we had quite a few people here. We had about 50 to 60 people that were participating between hybrid and in person. And it's this Notice, Talk, Act at School program that they presented, and we're really working to try to get this message into the community, into Oakland County and the schools. So that was a great program that we had as well last week. But now this week we have some things coming up. Dana and company, Dana and Kim and a couple of other leadership are going to present at the Senate Health Policy Committee coming up this week on Wednesday. And they're talking about managing behavioral health care in Oakland County. So it's an opportunity for us to get in front of legislators and talk about the important work that we do here in Oakland County. Also this weekend, we have our school mental health navigators staffing a table at Hazel Park Schools, a resource fair that they're hosting. So as you can see, some of our community events are really picking up, as they usually do. March, April, we start to really see an increase. And as we continue through spring, summer, we're going to be really busy with a lot of community events. Next slide. We also have another event coming up, a request to do a presentation and host a table at a senior living facility in Waterford. And a little typo that actually the JCC Special Needs Family Symposium happened yesterday, and we had some of our school mental health navigators there hosting a table as well. And then there's another big event that's coming up. The Pontiac community is hosting a Pontiac Health and Wellness Fair. It's going to be at the United Wholesale Mortgage on March the 31st. And we actually have one of our speakers on our training team. She's going to talk about catching hope, Sherry Rushman. She does a really good job speaking about hope and hope givers. So she's going to be presenting, and we're going to also have a resource table there as well. Dana's ramping up with meeting with the legislators. As you can see, she's meeting with Senator Thesis, Bear, Weber, as well as some representatives, Rogers, Vanderwall, and Whitesett. And then just to mention too that Dana was reappointed to the Autism Council, so that she's going to be on that council for another year. Another presentation that was requested for April, coming up in April on the 2nd, is at Sanctuary Church in Birmingham. And then we're going to be, it's in the works right now to host a autism provider resource event where we're going to bring autism providers in, have resource tables for them to talk about what they do and the services that they provide, and then bring some of those families in so they can learn a little bit more about those providers. That's going to be hosted here in the Michigan Room on April the 25th. And then just listing of our press releases. We already put out the press release for World Down Syndrome Day, and we put a press release out last week after we hosted the Disabilities Awareness Month event. And we're going to be announcing our new Chief Data Officer. I know he's not new, but we usually wait a little bit before we put those out. That's going out tomorrow. So we have some press releases going out this month. We have a couple more that are going to be kind of impromptu that are coming up as well. One thing I did want to mention too, just in relation to the question earlier regarding the needs assessment, it was brought to my attention that our response last year was the highest. The largest population that responded last year was from the individuals that we serve. So I just kind of want to circle back and answer that question for you. And then now I'm going to have Christine come up and join me. She's going to talk a little bit more about the end of the public health emergency.
Good evening, everyone. I just wanted to give you a quick community update on the public health emergency ending. The state is calling it the unwinding, the PHE. I sat through a presentation that they gave to legislators last week. The plan they have put together is really rooted in data based on the number increase of Medicaid beneficiaries starting in March 2020. They are adding additional staff. They're bringing people back from retirement to help. They are reassigning their staff to assist. So they have a comprehensive timeline put together. Letters started going out this month. We have been asked to hold off on our messaging until they release the toolkit, which is supposed to be this week. So I'm expecting it either tomorrow or Wednesday, and then we will mirror their messaging. They have social media plans, they have radio, television. It's a pretty comprehensive plan. We've developed an internal work plan as well to partner with our community leaders, our providers, and to ensure that people are aware that the redetermination process is beginning and how it impacts them. So I just wanted to let you know that there is a plan in place. I felt comfortable and confident in the presentation that they've really thought through and are looking at individuals who have received Medicaid benefits during the PHE and how we can reach out to them. Any questions? I know that was of particular interest to you, John.
Good memory. What about through the faith communities? I mean, these are going to be people that are difficult to get a hold of, so that's my concern.
Yeah, within our plan, we will be working with the faith-based, we'll be working with schools, we'll be working with law enforcement, so we have a rather extensive, we will be working calls. We're going to be doing an assessment of our providers to see what plans they have. So, for example, I know Honor has an event plan where they are going to help with the redetermination process as well. So I will get you the copy of our plan once I have their communication and what messaging they want us to use. I wanted to give you the whole package instead of piecemealing it, but we should have that for you this week.
Are we going to do any coordination with Centene and Molina? Because I think, aren't they our two largest Medicaid care providers?
So that coordination will go through the department. So they have staff that's assigned and designated to different groups and providers.
So that we're not calling, okay.
Yeah.
So I'm concerned about us reaching out to some of the same people that they are, and they have more skin in the, they have more financial skin in the game than we do for some of the folks they serve.
I think if we can contact people multiple times, we should. We've talked a little bit about starting too soon because sometimes people don't understand the urgency of the message until it's closer to that time. So I'm all for multiple people, contacting people multiple times to make sure that they aren't falling through the cracks.
Any other questions?
Yeah,
John Hall?
I had some questions going back to some of the other things that we talked about. The event with the American Psychiatric Association Foundation, do we know how many school districts participated in that, and who was invited to it? Was it administrators or counselors or?
Yeah, it was sent far and wide to principals, counselors, and superintendents, board of director, school boards. Do you happen to know? I don't have a list of those who attended, like the school districts that attended, but we can get that information for you, absolutely.
Yeah, I was just wondering, well, if you had a detail, that would be nice, but just the number of I think there's 28 school districts in Oakland County, so I was just interested in
if there was
knowing how many.
Okay.
Yeah.
Okay.
Because it sounds like there was a decent amount, 50, 60, but I wonder if it was from specific school districts or how that worked. And then the JCC Special Needs Family, what does JCC stand for again?
Jewish Community Service.
Okay.
Thank
you. Thank you.
You're welcome.
All right. Thank you both very much.
Thank you.
Sheila.
Okay, so next week I spoke with Mr. Landsman last week regarding the board study session. If you guys notice, there's a little bit of agenda change in time frames. So next week there's, just reminding the board, there's going to be an executive meeting that's going to hold from 4, No. From 5 to 6, or from 5 to 5:30. 5:30 to 6 is going to be the CEO Evaluation Committee meeting, and then from 6 to whenever is going to be the board study session.
On Thursday.
So,
All right.
So that's our normal board study session from 6 to whatever. But for our executive committee, we normally would meet from 5 to 6, but we're only gonna meet from 5 to 5:30, and then from 5:30 to 6 for the other subcommittee, which is for CEO evaluation. It's the same people,
Convenient.
but we have to have separate meetings to cover two separate agendas.
Okay.
and I will not be, I'll be off next week, so Veslicky will be here for the board meeting and for the stuff. So if you need anything, reach out to Dana and, and Victoria. So she'll have an automatic response on my email, so.
Okay. Thanks, Sheila. Thanks, Jonathan. Our second opportunity for public comment. Seeing none in the room. Any online?
I don't have any online.
Nobody for public comment. Item 6, board member comments. Any board members wish to comment? Adam, I see your mic is on.
Yep. Again, I'd just like to thank everyone who was involved in the presentations tonight, whether it be Anya and her team or Suzanne and Francis or Adam and Angel. Thank you very much for the very informative presentations tonight.
Okay, thanks, Adam. Any other board members wishing to comment? Jonathan? Oh.
Rena.
Hi. I just wanted to let all of my fellow board members know that I did make the difficult decision not to renew my board position at the end of my term this month. I've been very fortunate to have a growing practice and 2 growing children that have been taking a lot of my time, and I did not want to be an ineffective board member during that time. I feel very lucky to have worked with all of you in this capacity, and I certainly hope that I will have another opportunity in the future to return as a board member. Thank you.
Dr. Hans?
Yeah, I just want to thank everyone who presented today, especially the CERC committee report. It's a very important committee because it looks at the sentinel events, which are kind of, basically critical events. And I would hope that in the future presentation, some of the other committee members from the clinical side, clinical director or medical director or somebody be also present, because some of these questions are very sensitive and very thought-provoking. So I would hope that they will be part of this presentation. Thank you.
Jonathan?
Thank you. And I wanted to thank Rena for her service. I don't know if you'll be at our next board meeting and some others. Okay. So you're not going away, you're just stepping down as a board member. Okay. Thank you. And to thank Vicki and Adam and Angel for their efforts and things. I know it's a lot of stuff. It's a lot that you guys share with us. And this is one of those places, this and the study sessions, where we do ask a lot of questions and we drill down. So we do really appreciate it. Also to Yvette and John, thank you for stepping up in your respective committees to run your committee meetings today. So thank you.
Okay. Hearing no other call for comments, can I get a motion to adjourn?
You have that motion.
Oh, second.
Oh, there we go. Motion second. All in favor? Aye.
Aye.
All right. Thank you, everybody.